I have handouts up the back if you want them. One of them is a newsletter that I created, and you can take one of those.
Thank you, Brian.
Thank you.
Our second paper this afternoon is entitled Strategic Therapy and Hypnosis in Eating Disorders. It is presented by Gordon Carlson, and we'll invite him up to the podium now. If you all could please be seated so we could continue. We really do have limited time, and could I ask you to please take your seat and get the handouts at the end of the symposium in order to show courtesy to our next speaker. Thank you.
Okay. Well, I'm a licensed psychotherapist and the director of Mental Health Ericsson Clinic of Sweden. In Sweden it is known as the MHE clinic. It's a private clinic for psychosomatic disorders residing in a former hotel in the center of a small town called Mora. The clinic, which was founded in 1990, is licensed from the Swedish Medical Board and works with inpatient as well as outpatient treatment. The MHE clinic has room for 14 inpatients. These beds are used mainly for patients with anorexia or bulimia nervosa and other eating disorders. They are referred from physicians all over Sweden, and usually they've had their eating disorder for many years and have tried several other treatments earlier without getting any better. The ages vary from 14 years of age and upward. Most patients are between 17 and 30 years of age. The oldest patient we had was 63 years old and had been anorectic since puberty. When I started the clinic, I thought I knew a lot about anorectics and bulimics and how they should be treated. That was after I had had about 30 patients in therapy. Today we have seen about almost 600 patients with eating disorders. And I've learned that they all have a lot of differences too. You have to treat them in a unique individual. The MHE clinic is, to my knowledge, the only clinic in Sweden that uses intensive strategic problem-solving psychotherapy, along with pedagogical teaching and practical training to help the patient take control of the problems with food, eating, body, and social life. We have a rather unique treatment method. The patients stay at the clinic for 5 days and get intensive therapy each day, both individually and in a group setting. Then they return home for 3 weeks, carrying out carefully selected home assignments, tailor-made for each individual patient, to practice their therapeutic learning in their own social environment. Or, in some cases that are in a really bad shape, they go back to their usual hospital ward again. They come back again for another 5 days of therapy, after which they go back home for 3 weeks again, and so on, during 6 months' time. In total, that will be 30 days of intensive therapy. We call it an interval treatment arrangement. The idea is that the patient sooner or later will have to function in their own reality. So it makes an intensive therapy with practical training on their own. The idea is also to find a clinically fruitful balance between the positive effects of a high-structured inpatient treatment setting and the negative effects of hospitalization that often accompany longer periods of in-treatment. Compared to other treatment programs for eating disorders in Sweden, both in private clinics and hospitals, our program has proved to be very cost effective. After the first 6 months of therapy, we usually suggest to a referring physician that it is important to have, for example, 10 days of inpatient treatment that can be used during the following year in order to secure the positive changes that the patient has achieved and to prevent relapses. This is very important. Even if most patients during the first 6 months have taken control over their eating and have a body that functions all right, they still often are insecure and have a low self-esteem, so there is a risk for a relapse. If a relapse occurs, it usually is rather easy to help the patient get back on the right track again. The treatment method is rather comprehensive and integrated, developed during a 15-year period. The method is rooted in Ericksonian and strategic psychotherapy. We use paradoxical interventions and strategies of different kinds, like double binds, reframing, confusion, and so on. It is important to have the patients get out of their earlier strong beliefs. As we see it, you have to turn their old beliefs inside out. What they earlier thought was the right way to solve their problems and be happy was totally wrong. If they want to feel in control of their body and their life, they have to do many things in a new way. And because we have a limited time for therapy and have to be as efficient as possible, we try not to repeat earlier mistakes done by other therapists. Most patients we see have earlier been into hospital programs where they were fed, supervised, had to use a wheelchair between their bed and the bathroom, and so on, which led to a power struggle between the patient and the hospital room. If they've gotten any psychotherapy earlier, usually it has been psychodynamic therapy, which has left most patients we see frustrated over that they never got any answers to their questions on food and eating. Usually, their therapist said that their eating problem would solve itself as soon as they knew why they had an eating disorder. So, in order to talk the patient's language in a Ericksonian way, we give them more freedom and responsibility. And we talk a lot about food and eating, about how the body works and how to be a real master over it. We try to sell them the idea that we know how to give them the real control. Every anorectic or bulimic patient strives for control. We show them that their way of trying to reach that goal have led them in the opposite direction. If what they do doesn't work, they have to do something different, which is to eat food in a more proper way. So we use a lot of pacing and leading in therapy. To get the patient started in our new behavior as soon as possible, we tell, for example, a bulimic patient that we have 2 rules. The first one is to show respect for other patients. The other one is to be honest. We tell her that she is free to binge as often as she wants in her own room, but she can't steal the other patient's food in the kitchen. She has to go out and buy her binge food by herself. We tell her to vomit as much as she wants, but she has to do it in the toilet, not all over the bathroom. And she has to be honest about whatever she does. If I ask her about what happened yesterday, she has to tell me. If she tries to fool me, she can go back home and seek help somewhere else, as we say. Usually the patient answers that she doesn't want to binge or vomit in the clinic, that she's there to get better and so on. If I had said that she couldn't vomit at all in the clinic and that we would try to check her out all the time, she probably would have vomited a lot more. An important part of the treatment is a strategic pedagogical model of the anatomy and physiology of the body, to teach the patient how to eat and be satisfied with her body in a healthier way. In short, we teach the patient why it is necessary to eat various foods regularly, 3 to 4 times a day. In the beginning of therapy, we do not try to have the anorectic patient gain weight. The first thing is to get rid of her anxiety over food and eating. If the patient sees that she can eat more food without gaining weight, she feels more in control. After that, we help her to gain weight slowly in a way that she can accept. Another important part of the treatment is the built-in system of what I call big sisters. We do not start the interval treatment with new patients in all beds. Maybe 2 or 3 patients are new each week. The others have been there 1 or several weeks before. These big sisters are a great help for the new patients. They have already learned a lot about how to eat, and they have, in most cases, already started to change their own eating behavior. They are living proof for the new patients that it is possible to eat regular meals without getting fat, which of course affects the new ones in the most positive way. Other important parts of the treatment are cognitive therapy, body therapy, homework assignments, acupuncture, and hypnotherapy. Hypnosis is a valuable tool in helping the patient get well. In the early stages of our program, we use it mostly to help the patient relax and to build up her self-esteem and courage to change. We often do tape recording of one of the hypnosis sessions, which the patient can use during the 3-week periods at home, both to learn more about her inner resources and to help her get rid of anxiety when it occurs. Later on in the program, when the patient has achieved more or less control over her eating disorder, we often use hypnosis to help deal with various troublesome emotions and dysfunctional thoughts. It is important, as I see it, to think about what words you use with these patients. We will never use words in induction like heavier and heavier, of course. We rather use words like lighter and lighter. We do not give suggestions about her gaining weight or getting a normal body. Normal is the same as fat in the mind of an anorectic patient. Instead, we give suggestions about getting less underweight, about having just as much muscle tissue and building stones that her body needs to function all right. Not a bit more than her body needs. We also give a lot of suggestions about mastery and control, about having the real control over her food and her body. Also suggestions about getting more free and more healthy than most other girls. Usually they like those suggestions. They have strived for being thinner than all other girls. Now they can strive for being healthier than all other girls. For those patients that are interested in learning more about why they developed an eating disorder in the first place, we use hypnosis to get back to the sources. Still, most patients seem to have obtained all the insight they need and are not interested in working insight-oriented. But if we do, we don't do that in the beginning of therapy. First, the patient has to feel in control of her eating behavior. By the way, hypnosis is used both individually and in a group setting. For evaluation and follow-up, we keep in touch with the patients for 5 years. The results are rather promising. The patients fill in questionnaires when treatment begins, after 6 months, when treatment ends, and 2 years and 5 years after that. Fortunately, we have in Sweden a very good national registration. We usually can find a home address for most people, even those who move around a lot, as long as they are in Sweden. Can we put that on? Up to now, only 33 patients ended the therapy more than 5 years ago. They have all received and sent back their questionnaire. When treatment began, 39% had anorexia, 55% had bulimia, and 6% had eating disorder MS, according to DSM-4. After 6 months, when therapy ended, 33% did no longer fill the criteria for the eating disorder, according to DSM-4. 9% had still anorexia, 9% had bulimia, and 9% had eating disorder and MS. Next one. 2 years later, 76% did no longer fill the criteria for an eating disorder. 12% had anorexia, 9% had bulimia, and 3% had eating disorder and MS. Additional, 3 years later, 5 years after therapy ended, 82% did no longer fill the criteria for an eating disorder. 12% had still anorexia and 6% had eating disorder and MS. We have also another 239 patients that ended their therapy more than 2 years ago. 21 patients couldn't be reached or didn't send back the questionnaire, which leaves 218 patients. When therapy started for those 218 patients, 43% had anorexia, 47% had bulimia, and 10% had eating disorder and MS. Next. After 6 months, when treatment ended, 76% did no longer fill the criteria for an eating disorder. 8% had still anorexia, 5% had bulimia, and 11% had eating disorder and MS. 2 years later, 79% did no longer fill the criteria for an eating disorder. 8% had anorexia, 7% bulimia, and 6% eating disorder and MS. We have also more closely looked at the patients that still have an eating disorder, according to DSM-4, after the treatment. How many have gotten better and how many have no significant changes compared to when treatment began? We have defined better as an eating disturbance of some sort at a maximum of twice a week. For example, if a patient vomited several times a day when treatment began, and if she then has reduced her vomiting to twice a week, she is better. But she still has an eating disorder, of course. Unfortunately, we haven't got the time right now to show you the results in detail, so if we round off the results, we can say that approximately 80% get well again. Another 10% get better than before. We failed to help about 10% who show no significant changes, which is rather good considering both that the patients usually have had their eating disorder for many years and have tried several other treatments earlier, and that the treatment program consists of only 30 inpatient days during 6 months' time. That's all. One question?
Are your patients referred by a family physician, or do they come on their own?
All are referred by family physicians, psychiatrists, doctors at hospitals, always a doctor.
How often do you use hypnosis with these people? Every session?
No, not every session, but every week they stay at the clinic, we use hypnosis. Maybe it differs between the individuals. Some patients we use hypnosis almost every day. Some patients only twice a week. But we use it every week.
And is there a protocol that's followed, or is the hypnotic intervention tailored to each person?
Tailored to each person. We try to work Ericksonian.
Thank you very much. Some very interesting results. Our last paper this afternoon will be presented by a colleague who is from Denmark, Paul Erik Madsen, and his paper is entitled Results from Short-Term Hypnoanalytic Treatment of a Group of 64 Anorexic and Bulimic Patients.
Thank you.
It's a pleasure for me to be here and have an opportunity to present my paper. I have a background as a GP, and for 8 years I've been living in a private practice doing psychotherapy and very often applying hypnosis. The background and idea of this paper is to advocate for the use of hypnosis in the treatment of the eating disorders, especially anorexia and bulimia. I decided with my background as a GP to test my work and has tried to do a medical audit project of the results of treating about 60 clients with the above mentioned eating disorders. It is a consecutive project, a pilot project of the clients I have treated in my clinic from 1991 until 1996. A strict medical scientific investigation is, in my opinion, impossible to do with this group of clients. All information about my clients comes from my journals, my questionnaires, and telephone calls, and is collected in a little book that is the basis of this paper. It's my firm opinion that one as a clinical worker has an obligation to test one's work, to do medical audit. One or two case stories are not enough. It is necessary to test a greater material, and I find that lacking in the literature. So I urge my colleagues to do the same, make a medical audit project. The method and the techniques I apply will only be mentioned very shortly and in headlines. I prefer to work in a 2-hour session. That could be days in a row or with longer intervals. According to the results in the survey, it's no difference whether it's in intervals or in a row. The first 2 hours is a preliminary meeting without hypnosis whatsoever to obtain the anamnesis and to describe what I'm going to work with, what is called the separation paradigm, the traumatic separation theory, whose founder, Don Ibrahim, is here with us today. It's presented otherwise at this Congress. One has to get acceptance of the paradigm and in general to acquire rapport, otherwise I'll do no therapy. So I tell the client, go home, think about it, phone me if you want therapy the way I've described it. And about 10% don't call again. So I have a meeting with them for 2 hours, but they're not interested. Then the therapy follows, and it takes on average 10 to 12 hours per client. Again, each session is a 2-hour session. This therapy is partly eclectic and partly shaped to the individual client. You can say the therapy consists of several parts to work together to join in a kind of puzzle. It consists of making the client familiar with working with a light to medium trance. I'm not interested in a deep trance. And determine their ability to do so. Built in is a measurement of their main channel, whether they are visual, auditory, or kinesthetic. Then the client sets a positive goal for an outcome. That's an old NLP technique. I use anchors as they do in NLP, and the regressional work is done in a dissociated state of the client, so it happens on an imaginary screen to reduce the possible reactions. The therapy is based on NLP and using hypnosis to amplify. Then the traumas are uncovered, including uncovering the emotional conditions in relation to the birth. Unconscious personal conflicts are integrated by an old Gestalt technique refined by NLP, and reframing after that is done of patterns or symptoms. Finally, a tape is made to the client to work with in the future to promote the process. The tape is a resume of the therapy, and naturally it contains suggestions. Then to the focus on what I call the outcome. Could you please put that on if you want to help me with that? A lot of interesting information has stemmed from the survey, and the results or effects are very promising. Every client was asked about the effect, and they could answer effect at once, effect after some time, and no effect at all. The client has been given a number from 1 and up. Only clients who by one reason or another hasn't completed the therapy are excluded. So you can see here the first 10 clients and then results of that. You can understand what is in the boxes. But the last, I have now treated 70, I'm past number 80 clients. You can see there is a tendency down here in the last two columns. 7 clients positive, either at once after some time, 2 unchanged, and 1 is out because he didn't finish the therapy. So it seems you can see it goes nearly through. So that is the results. And they, I think, in 10 to 12 hours are very promising. The oldest clients till here, the first 40 clients, are now treated, ended more than 3 years ago. The trend found in the survey concerning the outcome seems to be a model, as I told you, out of 10, 7 positive, 2 unchanged, and 1 is excluded. The change to the better is a long individual process and consists of all degrees of change from only small changes to, in many cases, a process to a normal life. And that can be further detailed described in my little book, as not placed in time for it here. This process is going on from weeks to months as an individual process. It can be correlated to the changes in their personality that the client describes can occur in this process. It means, in the way of getting better, more self-confidence, reduced sensitivity to criticism, reduced dependency on other persons, reduced problems with anger and guilt, etc. And the same can be said, at least for the anorexic, regarding the changes in their eating patterns and the weight that can be described. Okay. Most of the clients that has experienced positive results find the way the therapy was done positive and the duration of the treatment suitable. This is not always the case in the group with no effect, naturally. So the information gathered in the survey in this group makes sense. Before treatment, the client has undergone therapy for a long time in the established system. The clients with a negative experience of the therapy had to a great part continued the treatment in the traditional system, and still, for most of them, no effect. We are discussing eating disorders, diseases that in our Western world seems to occur in a very high and increasing numbers. So there's a lot of money involved. Money that could be spared by the society if other ways of therapy could be found. By coincidence, I asked the clients who had experienced positive results, they asked the clients whether they will recommend this way to other persons, and why or why not. So not surprisingly, the group of clients who have experienced positive results told me they would recommend it. And they gave me many different explanations. But in clients who didn't experience positive change, most of them answered no, and in their explanation, many told me that they had never believed in hypnosis. So they were not enough motivated, and I was not clever enough to discover it. I find that very crucial. They are motivated. The largest group in my survey is the anorexia group, but a lot of the clients answered that it was both. I asked them about their diagnosis. I have one here. They could answer anorexia nervosa, they could answer bulimia, they could answer both, and they could answer other. And among that, migraine, diabetes was mentioned. So the largest part in my group is 33 that are anorexia, 13 bulimia. And a very big group, surprisingly to me, is a mixture. And the greatest part of these clients, they pass from anorexia years after years, then to bulimia. It is very seldom to go the other way around, but I have 2 clients who did that, started with bulimia and ended with anorexia. In this therapy, one of the cornerstones is the regressional work, uncovering traumas from the past and focusing on the early childhood traumas what is called in the limbic period, age 0 to 12 years old, and as long back as to the birth. On average, 4 to 6 traumas from this period was uncovered, and nearly all of the traumas had to do with traumatic separation in the limbic period from mother or another VIP. Only a few of these traumas had, as the MPD people assert, incestuous causes. With most of the patients, a birth trauma was revealed, and my definition of a birth trauma is as follows. Kinesthetic tension experienced somewhere in the body on regression to birth in a medium trance and dissociated. With the exception of only a few clients, all of the other clients were found to have had a birth trauma. How this is to be understood, I can't explain. But it appears to me that the birth trauma is of central importance. In some of the clients that had been treated a second time due to relapse, I found on the second occasion a birth trauma, and the client recovered when that was treated. In their anamnesis, more than average of the clients have had a complicated birth in some way or another. It seems to me that the earliest traumas are of the utmost importance, and that they are tied together due to repression of feelings connected to traumatic separation from mother or another VIP. And that an early trauma can reinforce the following traumas. So in my opinion, one has got to uncover the early childhood traumas. Otherwise, it seems like there is some kind of domino effect keeping going on and going on. The basis I mentioned of this kind of therapy is, as I mentioned, NLP and hypnosis. And the central ideas here concerning NLP is that our brain are able to repress, to delete traumas. But when deleted in the limbic period, it requires a generalization, and follow with that a distortion, and the distortion is at a clinical manifestation like anorexia and bulimia. The distortion, result of the deletion and generalization, is the personal unconscious conflict that has to be integrated as another cornerstone of this kind of therapy. And after that, when the conflicts are integrated, then the fabulous technique reframing can be applied and work, and will be done without regard me on any pattern or symptom I find I like to do therapy on. Then I construct personal anchors to the client to be used afterwards. I instruct them self-hypnosis, and I, as mentioned, make a tape of the essence of the therapy to be worked with in the future. So the conclusion with my paper is that therapy can be done against notoriously difficult diseases to treat in the existing world, namely the eating disorder. It can be done as fast as about 10, 12, 14 hours. Diseases that cost a lot of money to the society and severe distress to the stricken persons, and effect in the established system, in Denmark at least, no result. So I advocate to use hypnosis, to use it against eating disorders, and to do it more, especially I advocate to use it in the clinic so we can get better results. I have learned my way to work combining information from many people through lecturing and our books, and I can learn you to do the same therapy. So let us get on. Thank you.
I have a question, please.
Yeah, we have a couple of moments left for questions.
Yes.
The lady back here was first, and you can be second.
Okay, thank you, sir. How did the clients discover that they had a birth trauma, and how did you treat it?
They had, as I said, they had kinesthetic tension in their body, somewhere in their body. Could be in the head, throat, thorax, and in the gut. Up in the gut, down in the gut. And that's the same tension they have in their body when they in their growth up life or young life, 14 years, in the adult when they get their anorexia. When they have the anorectic symptoms, the same tension is in the body. So you can travel the tension from here now, either anorectic or bulimic, back to the birth at the first time. I don't go beyond birth.
Right.
Sir?
Yes. Now, I am the author of traumatic separation theory, which Dr. Gallamatzen has acknowledged, and I would like to draw the attention of everybody here to the fact that the birth regression technique, which he has made the cornerstone of his therapy, is one of the most dangerous techniques I know of to use with people who have eggshell personalities. Anorexia is a dangerous condition. The suicidal rate is pretty high. Those figures that you've given there, anorexia, bulimia, they do not conform to the diagnostic criteria laid out in DSM-4. They are diagnoses made by your patients. And to do a life scan and a birth trauma regression, it's one of the worst things I've ever taught in Denmark. And because you don't work with colleagues, you're working alone, nobody to compare your results with, and I've had quite a lot of tragic, thank goodness not, outcomes that could not be put right, but certainly even with workshops in Copenhagen, in using the birth trauma technique with colleagues to teach them how to do it, we've had some very disturbing psychotic-like breakdowns. And I in England have had the same. So now I do not teach the birth trauma regression. I think I must have been in a very sadistic frame of mind at the time. It is a rape of the unconscious mind. That must never be used. It's my technique. I am the author of it. I know it's dangerous. Don't use it, for goodness sake. And don't do a life scan the way I describe it, to challenge the defenses and to look for the tension in various parts of the body, as he talks about. It's the worst thing you can do. These people with eggshell personalities can crack up. And I think that most of your cases that you have been treating, this enormous number, they are merely fashion freaks with learned responses and food fads. To ask patients whether they think they've got anorexia or bulimia is a very, well, I think, ridiculous way of making a diagnosis. I know it's unfair to criticize a colleague. I was a learner myself. Years ago, I had to learn from older people. You are at the beginning of your career using dynamic approaches, and I hope that you will take my advice. And I hope this audience will never use these techniques. It's dangerous. Thank you, Mr. Chairman.
Very good. Any other questions? He does not wish to respond. Dr. Madsen doesn't have anything to say. Anyone else have a question? We have time for one more before we stop.
Yes. What was the average ages of patients that you were treating?
Their ages,
Yeah, average ages.
anorexia, that's about puberty from 12 to 17. Bulimia, that's a little later in the adolescence. Anorexia can't separate from being a child to be sexually mature. And the bulimia can't go from the adolescence to adulthood, can't separate from that phase. So they're 3-4 years and bulimia later. That's the normal system. But sometimes you have an anorectic 20 years old.
Yes.
But she behaves like she is 12 years old.
Well, I want to thank our presenters of the 3 papers and you for coming. Why don't you join me in expressing our appreciation.
Just get the title. Is Dr. Consuelo Casulo from Milan, who's going to talk about hypnosis with emotional disorders.
Yes, thank you. So this is the title of my presentation, and I'd like to start with a quote. And for me, this is the most, the quote that represents in a very clever way the meaning of emotion. I hope you agree with me. Elster says emotion is something. Elster says that emotion is something that hinders us from sleeping. I like this because it's not a serious quote, but I think this is true. If we are very happy, the happiness hinders us from sleeping. If we are very sad, these emotions hinder us from sleeping. So what is emotion? Emotion is a relationship between the patient and the environment. So the emotion are affective reactions, and each emotion contains different components and functional attributes, which specify what to do to respond appropriately to a particular emotional situation. The responses consist in changes in the state of willingness to act. I will present a quote that is a quote by Frida. Frida says, emotion involve change in action readiness by definition. Oh, here you are. She is the chair.
I am chair here?
No, you're not. Situation, physical reaction, emotion, cognitive aspect, and behavior mutually influence each other and interact together. In fact, negative thought is fed by negative emotion, and it implies that the patient is not in harmony with those around him or her. Positive thought is fed by emotion, such as love, appreciation, and it implies that the patient is in harmony with the people and the universe that surround him or her. Emotion modulates or bias actions, provide information, signals events that are relevant to the patient concerned, and motivate behavior to deal with those events. So psychotherapy of emotion and hypnotherapy of emotion. Psychotherapy is basically a set of procedures designed to repair emotional disorder on individual level. The hypnotherapist helps the patient to organize a better experience, to have appropriate perception, and to make future plans. The task of the hypnotherapist is to help the patient to cope with negative emotions and to gain control of his or her emotions. Coping and control imply flexibility, not simple inhibition, and the ability to respond in the way the patient wants, whether that entails the inhibition or expression of emotions. So the hypnotherapist helps the patient, in coping with negative emotions by stimulating actions on the environment or people in order to change the unhealthy relationship, hence the relational meaning and the resulting emotion. With disassociation, in order to pay attention mainly to the non-emotional aspects of the event. With reframing, in order to change the way the relationship is appraised, hence the relational meaning and the resulting emotion. So the hypnotherapist as an emotional teacher. The hypnotherapist shapes patient attitudes, beliefs, thoughts, emotions. The therapist labels emotion as embracing a constellation of situations, sensations, and behavior. The therapist proposes appropriate social behavior for specific situation, attributing social meaning and rules. The therapist helps the patient to monitor his or her emotional behavior, to conform to socially accepted standards and to be effective. The hypnotherapist teaches emotional skill. These emotional skills are mainly four that are contextualized, that recognize the most useful and appropriate emotion according to the very situation, know how to choose appropriate and useful ways of expressing emotion, the expression part, know how to make use of emotions, even unpleasant ones, to generate useful behavior, and know how to prevent the manifestation of paralyzing of an unpleasant emotion, prevent. So let's start from the first point, contextualization. Contextualizing is the process whereby a specific situation is associated with the most appropriate emotion. And this requires that the patient become able to orient him or herself towards the effect that different emotions will have in different situations. Select the most useful and appropriate emotion for that specific situation before, during, and after the event. Access to the selected emotion by a memory fantasy, body adjustment, directing attention, remodeling the meaningful components, reframing, identifying what is there, what is missing. Also, breaking the pattern of cause and effect, changing perspective, detaching oneself from what is happening, shifting attention towards another stimulus, processing information, or physically leaving the field. The second point was express, how the psychotherapist teaches how to express the emotions. In order to express emotions, it's important to understand them. The path to an awareness follows the following stages. Reconstruction through self-observation of behavior, thoughts, states of mind, expectation, memories. Reframing of negative elements. Rediscovery of inhibited emotions. Discovery of significant multiple parallels, imaginative symbols, and decide whether the patient wants and is able to express them. Third point, access behavioral options, context, situation, right timing, person involved, appropriate verbal and non-verbal methods. Take the emotion for him or herself, contextualizing, legitimizing, specifying what causes and what she wants from the other person. The third point is the utilization. So every emotion is a sign that tries to communicate something about the patient, him herself, and the world around her, them. Each emotion has a number of functional attributes which specify what is needed in order to respond appropriately to that emotional situation. Also, a generative chain of emotions guides towards positive results and encourages the patient to do something about his or her well-being. It invites them to access situations in different ways, setting priorities, finding other options, satisfying personal criteria. And the last one is the prevent, how to prevent. So after taking stock of responses of the patient to certain stimuli, the therapist brings the patient in a position to decide in future to prevent certain emotional reactions in particular situation. And now I will conclude with 7 commandments of emotion. As I am very fond of the magic number of 7. The first one is, when you fall in a state of anxiety, direct your attention to the resources that you have and to your future plan. Second one, question any irrational or toxic thoughts. Third one, take risk and accept the challenge. Fourth one, when you experience a dysfunctional emotion, find the appropriate one. Fifth, accept the thing that you cannot change, change the thing that you can change, and then recognize the difference between the two. 6, make time for your personal interests and pleasures and stay in touch with happy and healthy people. 7, exercise your cognitive, behavioral, and emotional flexibility. Thank you.
Our next presenter is Dr. Ayala Laser from Chicago, and her title of the presentation is Art Hypnotherapy as an Agent of Change with Thought and Affective Disorders.
Okay, I'm encouraging you to take a stick of clay here and mold it while I speak,
think will give you a little experiential feel. Dr. Peters the other day talked about radical constructivism, and he claims that the cortical processes taking place while we perceive in perception are very similar, any color, are very similar to the processes taking place while using the imagination or in the hallucinatory or hypnotic state. However, we know that cortically impaired people suffer from serious deficits in their imagining faculties with severe affective disorders, manic and depressive. We see a break in the concentration flow, breaks in spontaneity. Dr. Spiegel also mentioned the Dionysian style where cognitive communication is impaired. So this is where nonverbal art hypnotherapy or hypnotherapy has a significant role in making some changes and helping a person to get into the hypnotic state. This is done both for inductions and for treatment suggestions, and it works very, very effective with people who are, especially with people who are complete and unable to abstract. Now, to complicate treatment, we have many patients who are refractive or resistive to psychopharmacology. So, okay, as Dr. Peter indicated, the more sensory input, the more real the perception is. And perception and reality are the same as far as at least the radical constructivism or the empiricism. Now, nonverbal doesn't mean mute. We use words to enhance the experience. And what they do is they supply the form on the perception, on the color. They supply the abstraction, they supply the bridge to other situations. However, there is some generalization that takes place by the experience itself without the words. Now, the active art hypnotherapy allows this joining of all dysfunctional associations, creating new ones via art. Examples, if the idea, ask for what I want or express myself, was previously associated with either failure or punishment, and many of the patients have been not only experiencing failure, but severely punished for asking for what they want or expressing the feeling. The intervention of remolding, this is just one example, remolding and redo situations symbolically provides a new association, which is the reinforcement of no failure, no punishment, satisfaction, realization that new things happen due to manipulation, to constant experimenting. If the idea is that the unknown future brings associations such as harmful separation from the familiar or loss of what I know, negative, and it was expressed, let's say, by a storm, a person drawing a storm, the new association, which was achieved through molding or pasting, collage, putting new facets, new strata on top of the old ones, was that I can get improvement. I can get to try new solutions to an old problem. And in case of the storm, that I asked people to draw a house and the weather around it. The person drew the house in a very stormy weather, very dark, clouds, kind of ominous. And as he progressed,
he ended up with a lightning rod next to the house. So this was the solution that came without any words. Okay. Induction, natural induction is facilitated via the clay molding. The attention is focused on the process, okay? Allowing the patient to free themselves from anxiety in regard to productivity and control. And they are asked, they're invited, no need to tell your hands what to do. No need to make anything. For now, allow yourself to feel the clay. You may notice the resistance at first, how tender and warm it becomes as your hands continue moving. Okay, here I suggest dissociation of your hands. Notice its particular smell, color. Feel it a little longer before any shape may be formed. So the suggestions have to do with absorption, dissociation, and process for sure. I try to delay product to free people from feeling that they have to make something. You may notice that the longer you play with the clay, the more flexible it becomes. Feel the strength of your fingers on the clay. So there are suggestions of internal strength and flexibility. And while the words, again, put the shape on the perception is very powerful. Okay, treatment. If we take depression, there are 5 major issues: powerlessness, hopelessness, meaninglessness, isolation, social withdrawal, identity, or the reality of self in the world as well as the reality of the world. Now, my patients are incarcerated long-term. Am I involved with the law? Mostly Axis 1, sometimes coexist with Axis 2. Chronicity and incarceration exacerbate those characteristics which are depleted energy and inability to carry intentionality. Okay. Now, powerlessness is incompatible with the sense of manipulation of matter, of active sensory involvement, especially via group project and transitional objects. Okay, so we are engaging in an activity which is incompatible with that feeling. Failure is bypassed by removing expectations altogether. The suggestions is to avoid intending, to just play. Hopelessness. Constant molding and transfer